Good evening, everyone, and thank you for joining us for the Hernia Ultrasound webinar presented by Andrew Grant. My name is Catherine Smith, and I am the Ultrasound Product Specialist at Philips Healthcare. Before we begin, there are a few housekeeping matters that need to be covered. If you need technical assistance, ARCAN and staff are available at all times. Please type in your issue in the Q&A section to the right of your presentation screen, and they will assist you. All the lines will be muted to minimise noise during the presentation. So if you do have a question for Andrew, please type it in the Q&A panel. We will address as many of the questions as possible at the end of the presentation. If you do feel the slides are too small, you can maximise the size of the window by clicking the top right square, and the presentation will expand. Most importantly, to get your CPD certificate, there is a box below Q&A called Certification, as well as a yellow certificate icon at the bottom of the web page. Once you finish the webinar, the icon will turn green and you can click to download the PDF certificate. Please note, when the webinar ends, you will not be able to download the certificate. If you're watching the webinar on a tablet or a smartphone, you will not see the CPD certificate icon. All you have to do is open the webinar from your computer using the link that was given to you, and you will see the icon available to you. You will not be asked to watch the webinar again. If you do not have access to your computer, please email melissa.chen1@philips.com, and Melissa will email a CPD certificate to you. Before I introduce Andrew, I would like to introduce you to our EPIC, our premium ultrasound system, which takes you to a new level of diagnostic confidence, bringing together our innovative technology, ergonomics, and our unique Insight technology. Insight is built around a new precision beamformer and massive parallel processing to make it our most powerful system yet. This unique combination enables the EPIC to receive and process an enormous amount of acoustic data and apply a virtually perfect focus down to the pixel level. So for you, the customer, this allows faster frame rates, increased penetration, and image uniformity without compromise. Both the EPIC and Affinity systems provide versatility with a universal platform for general imaging, shared service, cardiovascular, and obstetrics and gynecology. The EPIC gives you clinical clarity across all applications using our pure wave technology with the C51, C92, and C10-3D, as well as our high-frequency L18-5 to smaller parts and MSK. When you partner with Philips, we give you the benefits of future-proofing with all our innovative technologies, including image fusion, X-matrix, and shear wave elastography. The EPIC and Affinity share the same DNA with similar touchscreen and control panels, as well as the advantage of seeing transducers. The Affinity is our premium, high-end system designed for your everyday with walk-up versatility, ergonomics, and mobility, as well as stunning image quality. Our high-frequency L18-5 is perfect for all your MSK applications, providing exceptional IQ across all aspects of MSK. So now I'd like to introduce you to Andrew. Andrew Grant is currently working at St. Vincent's, East Melbourne, for MIA Radiology where he is an ultrasound supervisor. Many of you would know him from various ASA and ASM lectures. In addition to this, Andrew has also worked in many countries, sharing his knowledge in sonography and radiography. Besides being an exceptional sonographer, he has also taken a step further. Andrew has a commercial pilot's license, which he utilises to fly in and out of rural areas. So the title, The Flying Sonographer. Since completing his radiography training in 1992, Andrew has worked for one of the top medical clinics in Western USA, UCLA Medical Center, where he has been responsible for setting up their MSK ultrasound program. Tonight, Andrew's presentation will review the literature and describe the normal anatomy of the abdominal wall and inguinal regions. Please join me in welcoming Andrew, and thank you again for joining us for the latest Philips webinar. And now I'll hand over to Andrew.
And thank you very much, Catherine. And I'd like to take this opportunity to thank Philips for asking me to give this presentation, and I'd like to welcome all the sonographers around Australia and in New Zealand for joining us this evening for our talk about hernias. So tonight we are going to describe hernias and their different types. We will describe the anatomy of the abdominal wall and the inguinal region. We'll show some examples of some hernias, and we'll also describe some complications. As I'm sure you're all aware, a hernia can be defined as a protrusion of a part or structure to the tissues that normally contain it. Now, in the abdominal region, they can occur more commonly in the inguinal and the femoral region, as well as in the midline, be it umbilical, paraumbilical, or epigastric. Hernias can also occur through an incisional scar. We'll also have a look at some Spigalian hernias, as well as a divarication of the abdominal wall. Let's have a look at the anatomy now, a quick review of the anatomy. Now, the anatomy of the anti-abdominal wall comprises multiple muscle and fascial layers. Centrally, we have the two abdominal rectus muscles. Laterally, we have three muscle layers. Superficially, there's the external oblique. Next in is the internal oblique, and the deepest is the transversus abdominis. Now, these lateral muscles have very wide, flat tendons, and we call these tendons aponneuroses. And these aponneuroses combine in the midline to form the linea alba, and lateral to the abdominal rectus, they combine to form the linea semilunaris. We can see there in between the obliques and the recti. Now, if we have a look at a transverse section through the lower abdomen, we note the two recti muscle midline. We also note the external and internal obliques, as well as that transversus abdominis we see laterally. We can also see those aponneuroses, or those tendons, and they combine lateral to that rectus to form the linea semilunaris, and again, midline, they form the linea alba. And if you have a close look, there's you can see in brown in that diagram there, deep to all of the muscles, there's a thin fascia called the transversalis fascia. Now, it's important to note that fascia runs across the entire abdominal wall, and it's important to note that fascia when we discuss inguinal hernias just a little bit later on. Now, let's have a look at the inguinal canal. Now, the inguinal canal is a short, narrow diagonal passage in the lower anterior abdominal wall that allows the passage of the ilioinguinal nerve and the somatic cord in males and the round ligament of the uterus in females. Measures about 4 centimetres in length and is surrounded and wrapped by those tendons or those aponneuroses of those three lateral muscles, the external oblique, internal oblique, and that transversus abdominis. Now, the arrangement of the arrangements of these aponeuroses around the canal mean that with tension of the abdominal muscles, the canal will be closed and will be held closed to try and prevent any herniation of the abdominal contents going through it. Now, as we can see in the diagram there, that exploded diagram, the inguinal canal can be considered as a simple tube. It has openings at each end. Superiorly, we have the deep or the internal ring, and inferiorly, we have the superficial or the external ring. We can have a closer look at those now. First of all, we'll have a look at the deep inguinal ring. Now, the deep inguinal ring is merely an oval gap in that transversalis fascia, that lining we spoke about earlier. There's a normal hole in that lining. We can see the transversalis fascia there in that picture, is that sort of skin-coloured layer right at the very top of the image. There's a oval gap in that transversalis fascia that allows the passage of those nerves and arteries and what have you. And this deep ring lies about 1 centimetre superior to the inguinal ligament, and most importantly, it lies lateral to the origin of the inferior epigastric artery. That's a very important landmark. We'll keep coming to that multiple times. The deep ring is lateral to the inferior epigastric artery. We'll show you a little bit later on the best way to find that origin of the artery. We go down to the inferior end of the canal now, which is the superficial inguinal ring, and that's merely a triangular opening in the aponeurosis of that external oblique. We can see it there. It lies immediately lateral and superior to the pubic tubercle, and the pubic tubercle is just that edge of the pubic bone we can see quite often on an ultrasound. So just immediately lateral and superior to that is the superior inguinal ring. It'd be easy to see the somatic cord there in a male. So let's have a look at some scanning techniques now. Usually we like to use a nice high-resolution linear probe. Occasionally we may need to use a lower frequency for larger patients. Initially we perform the ultrasound supine. Now, an effective Valsalva manoeuvre is critical for this examination, and it really is worth the time to get the patient to perform it correctly. Now, as I'm sure we're all aware, a lot of patients do find a Valsalva quite difficult sometimes, and you have to be careful that you don't get spat on or blown at when that happens. If I had $1 for every time a patient gave me a raspberry when I asked them to Valsalva, I would be a rich man. I usually ask the patient to push your stomach out and make yourself go fat. Obviously, you need to be perhaps a little bit tactful sometimes when you say that. Sometimes I might actually ask the patient to bear down like they're on the toilet. Once again, do need to be a little bit careful. I know other speakers have spoken about this in the past, and I've heard of some sonographers. They ask the patient to put their thumb in their mouth and try and blow their thumb up like it's a balloon. Now, I've never done that, but you do whatever works. And as I said, it really is important to have a few practice runs before you actually have a look for a hernia. I don't get the patient to cough. Unlike a GP or a doctor, when they're clinically examining the patient, will often get the patient to cough. When a patient coughs, things move too violently and too quickly, and you tend to lose your landmarks. And it's actually interesting to note that a hernia is often better appreciated during the relaxation immediately after a Valsalva. This is when the hernia, if there is one, will return back to its normal position. And as I said, this is because that sudden movement when the patient Valsalvas, you tend to lose your landmarks, and you can often see that hernia sliding back into position much more clearly than you can when it comes out. And if you've done the examination and you don't see a hernia, it's always worth having a look with the patient direct and doing the normal Valsalva manoeuvres again, because often you only see these hernias when the patient is actually standing. Okay, so as I said earlier, the most important landmark when we're scanning the inguinal canal is the origin of that inferior epigastric artery, and it originates from the external iliac artery. And on the next slide, we'll show you a little clip of the best way to find the origin of that inferior epigastric artery. Once you've found that origin, slightly to the lateral of that will be the deep inguinal ring, and then all you need to do is turn the probe around so it is aligned along the long axis of the inguinal ligament, and then you should be able to see, obviously in a male, the normal spermatic cord. It's a heterogeneous structure with hypoechoic areas and hypoechoic tubules within, and there will be some vascularity. Obviously in females, it's a little bit harder to see. You can see that ligament, but it is much easier to see in the male. Now, finding the origin of those inferior epigastric arteries, what I normally do is start a little bit higher up in the abdomen within the rectus muscle. Higher up in the rectus, the inferior epigastric arteries actually are in the middle of the rectus muscle. As you scan down, inferior epigastric arteries will come out of the muscle posteriorly, and you can follow them all the way down to the origin. As we'll see here on this scan, there we are in the middle of the rectus with those inferior epigastric arteries there, scanning all the way down, keep coming down until we see it originate from the external iliac artery, and just above that and laterally we can see the deep inguinal ring. So that's our really important landmark. We can see the deep inguinal ring there coming up in blue. There we are, and the origin of the arteries are coming up in red. So once you've found that very important landmark, as I say, you can just twist the probe and you should be able to see the inguinal ligament, and the canal should easily visualise. We can see it. There it is there. A little bit hard to see on this image there, but if you go to the next one, we should be able to see a little colour put on it there. So we've got the blue line there is the inguinal canal. The red circle there is the origin of the inferior epigastric arteries, or inferior epigastric artery. Lateral and superior is to the left of the image, and medial and inferior is to the right of the image. So we can see the deep inguinal ring there is to the lateral aspect of the inferior epigastric artery. Now, once you've found the canal and you get the patient to strain, you can see here the normal canal can be seen to dilate slightly and move both inferiorly and posteriorly. Now, that movement of the canal is quite normal. The canal is allowed to move quite a lot without it being a hernia. Just as long as nothing goes into the canal, then it's not a hernia. But you can get quite an extensive movement in some places of the canal, and as I say, just as long as nothing enters the canal, that's not a hernia. Now, I often like to look at the deep inguinal ring in a transverse view, as we can see on this next clip. We can see once again the deep ring there in blue, and as the patient stresses, as they valsalva, we'll see the deep ring move posteriorly and laterally. Once again, that's quite a normal movement. You can see on this clip here that there is quite a lot of movement of that canal, and once again, that's quite a normal amount of movement. But we can see there's nothing going into the canal, so that's there's no hernia there at all, which is quite good. So we'll move down now to the superficial ring. We can hear a little clip with the yellow line here is that aponeurosis, is the external oblique we saw earlier, and the canal there is in blue above it. And as we scan through, we can see the canal there piercing through that external oblique aponeurosis, and that is the superficial ring right there. Now we can see the canal going into the canal proper a little bit more superiorly. And as we come down again, we can see the canal coming down, coming up towards the probe, piercing that external oblique, and that is the superficial ring right there. So we've had a good look at both ends of the canal. Superiorly, we've had a look at the deep ring. Inferior, we've had a look at that superficial ring, and we've had a look at the entire canal all the way through. So we know we've covered the whole area. Now, there is some basic terminology that's pertinent to hernias that need to be covered. Now, if the contents of a hernia can be pushed back into its normal position, that's known as reducible. That's a reducible hernia. Now, if the contents cannot be pushed back, that's known as an irreducible hernia, or another name for that is an incarcerated hernia. Now, if an incarcerated hernia may or may not have compromise to its blood supply. If there is vascular compromise, then that hernia is referred to as a strangulated hernia. Now, obviously, if there is bowel involved in that strangulated piece of tissue, then that can become a surgical emergency because we don't want the patient to perforate and get peritonitis and all the complications that result from that. And that's, in fact, one of the main reasons why we perform a hernia ultrasound is to establish if bowel is involved or if there is any strangulation of that bowel, because that is going to dictate the immediate management of the patient. So just once again, some of the terms you need to try and remember. An incarcerated hernia is one that isn't able to be removed, pushed back into position. An incarcerated hernia can either be strangulated or non-strangulated. So you need to be able to differentiate between those terms. Now, because trying to determine if a hernia is strangulated or not is one of the main reasons for doing the ultrasounds, what are the signs of a strangulated hernia? Well, there are a few signs as sonographers we can look for. Any factor there may be echogenic. You may have free fluid within the hernia sac. The bowel wall thickness in a hernia may be greater than 4 millimetres. You can get fluid within the herniated bowel. You can get dilated loops of bowel within the abdomen. You can get absence of blood flow within the hernia, and you might even get absence of peristalsis within the hernia. Now, in 2001, Thomas Rettenbacher did a study of, it was 149 hernias, and as we can see from those first three signs, which should be relatively easy for us as sonographers to detect, with ultrasound, these are good indicators of strangulation. So the things you're looking for are fluid within the hernia sac. You're looking for bowel wall thickness that is greater than 4 millimetres, and you're also looking for fluid within that herniated loop of bowel. So those are the three signs that you should be looking for, and if you see any of those signs, that is going to raise the possibility and suspicion that there is a degree of strangulation going on there. All right, let's have a look at inguinal hernias now. An inguinal hernia occurs when the abdominal contents enters the inguinal canal. Now, most commonly, it just contains a mental fat, may contain bowel, may contain peritoneal fluid, and in women it may even contain an ovary. That has been seen before. It is by far the most common abdominal wall hernias, and inguinal hernias are in fact much more common in men than they are in women, obviously because of the canal is larger to take the spermatic cord. Now, inguinal hernias can either be indirect or direct. Now, an indirect inguinal hernia is when the hernia sac enters the inguinal canal via the deep inguinal ring. Remember that deep inguinal ring is just the normal opening of the inguinal canal that is supposed to be there in every single person, and it's lateral to the origin of the inferior epigastric artery. There's that landmark again. It is the most common sort of inguinal hernia. It's more common in younger men, and it may extend all the way to the scrotum. That's because there is no transversalis fascia holding the hernia in, because it goes through the deep inguinal ring, and the deep inguinal ring there is a normal hole in the transversalis fascia. But we can contrast that with the direct hernia, where the hernia sac enters the inguinal canal via the posterior wall. So it doesn't go in through the normal opening of the canal. It goes in through a false defect in the posterior wall. So that's going to be medial to the origin of the inferior epigastric artery. Much more common in older men. And because the hernia sac has that transversalis fascia as a covering, it very rarely extends into the scrotum. It sort of holds it only into the inguinal canal. Now, when I've given this talk previously at various conferences, I've used an example of a tube and a sort of a simulated hernia. So I've done a little video clip here, which hopefully will work, which is a little minute clip, just to try and give you a difference between direct and inguinal hernia. So if this works, which hopefully it will. It can sometimes be easy to think of the inguinal canal as a tube with two open ends. The upper end is the deep inguinal ring, and it lies lateral to the origin of the inferior epigastric artery, and the other end is the superficial ring. Now, in indirect inguinal hernia, the abdominal contents, represented by this huck towel, enters through the deep inguinal ring, the normal opening of the inguinal canal, and passes straight through the canal, goes all the way through quite easily, and comes out the other end, and that is an indirect inguinal hernia. And we can contrast that with a direct inguinal hernia, where the abdominal contents passes through a hole in the posterior wall about here, and it goes up, but because of the different linings of the hernia sac and the angles, it can't go all the way down through to the superficial ring, so it stops. So this is a direct inguinal hernia when it comes up through the posterior wall, but when it comes in through the normal opening of the inguinal canal, this is an indirect inguinal hernia. That's the difference. Okay, so let's have a look at some examples of some hernias here now. So the first one is an indirect inguinal hernia. And once again, in blue is that inguinal canal. Red is the origin of the inferior epigastric artery. So we have this indirect hernia when the patient strains, we'll see the fat coming in right through that deep inguinal ring, right through that normal opening of the canal. We can see a very horizontal movement of the fat. That's another good sign that it's an indirect hernia, if the fat or the content moves horizontally back and forth. So that hernia is going through the normal opening of the inguinal canal. So it's an indirect hernia. That's coming in lateral to that inferior epigastric artery. And that's a fully reducible indirect inguinal hernia. We can have another example of that now. Here's another indirect inguinal hernia. Once again, we can see our inguinal canal here in blue. Lateral is to the left of the image. And we can see here now as the patient stresses, we can see the abdominal fat moving quite horizontally, coming straight in through the canal there and going all the way in and then coming back. So that horizontal movement, the primarily horizontal movement of the fat is another good indication that it's come right through that normal opening, that deep inguinal ring, and it comes through the canal. Now we can contrast those cine clips with and let's do that one again. We can contrast that now with a direct inguinal hernia. So once again, we have in blue there, that's our inguinal canal. And this time, if we look, we can see the abdominal contents is going to come straight up towards the probe and then turn 90 degrees and then go down the canal. These video clips are a little bit slow over the internet tonight, so I do apologise for that. But we can see here, instead of going in the normal opening, this is coming up through a defect in that posterior wall. So you can see the fat coming up through the middle of the image, turning right and making a 90-degree bending going down the canal. So this is a direct inguinal hernia because it's not going in through that normal opening, it's going in through a defect in the posterior wall. We can see there's an upward movement of the fat before it moves down in the canal. So that sort of up and then to the right movement is another good sign that it is a direct hernia rather than indirect. And we have another example here, I trust. Yes, there we are. So once again there, we can see the fat coming, when it comes, yes, here it is, coming straight up towards the probe, turning over 90 degrees and going down to the right of the image. You can even see the origin of the inferior epigastric artery there on the left. So therefore we know we are medial to the origin of those vessels. There it is there. So if it's medial and it's coming up and then going down, that's going to be a direct inguinal hernia. And we can see once again there in blue, there's our canal. There's the origin of the inferior epigastric artery in red. And we've seen how that fat's coming up medial to the origin of the inferior epigastric artery. So that's going to be a direct inguinal hernia. Moving on. So here we have an example of an incarcerated inguinal hernia that contains bowel. So we can see the bowel there is in the inguinal canal. This wasn't able to be reduced at the time. It wasn't particularly painful at all. The patient just had a lump in their groin. You can see that that is bowel there. But there's no fluid in that bowel. There's no fluid around the outside of the bowel in the hernia sac. So that's actually an incarcerated hernia because it couldn't be reduced. But there's no signs of strangulation there at all. So that's an incarcerated inguinal hernia with bowel. Now we can contrast that with these next two slides. Now we don't always have to have video clips to show a hernia. You can even do it without doing cine loops. We can see the calipers there have marked the position of the deep inguinal ring, and we can see there sort of a normal width, and we can see there's no fat or no area. Hopefully people can hear me now. Okay, so sorry about that. Something happened to the phone line there, so I think we should be back on. So as I was saying now, we have a strangulated hernia, and thank you, Sammy, saying I'm back. So, yeah, we have a strangulated hernia here with bowel. So we can see there is fluid within the bowel there. We can see there's fluid in the hernia sac. Now, this was actually quite painful. This patient had just spent a whole weekend in the garden doing some gardening, and it came up with a painful lump. And this was a strangulated hernia with bowel. So that, you know, is going to need to go sort of straight to a surgeon and to have that looked at, because you don't want that bowel to perforate. All right, let's have a look now at some femoral hernias. Now, a femoral hernia is when we get the abdominal contents entering through the femoral canal. Now, it represents approximately 20% of all groin hernias. It's much more common in women. And you'll see the hernia coming posterior and inferior to that inguinal ligament. And you'll also notice it will be medial to the femoral vein. So these are, to look at the femoral hernias, you normally have the probe in a transverse alignment, inferior to the inguinal ligament, and just at the level of the femoral veins. You get a patient to Valsalva as required, and if there is a hernia, you'll see it coming up. You see it coming up next to that femoral vein. There's a little diagram here showing that the sac of the femoral hernia there is in close association there with the femoral vein. You can see it is inferior and posterior to that inguinal ligament. And that can be contrasted there with the sac of the indirect inguinal hernia that is coming up more superiorly. As I said, there's now look at it transversely, so we can see on this next cine loop here, transversely there is a patient with Valsalva's. We can see that fat coming in there medial to the femoral vein. Here it is again, often compresses the femoral vein, so that's a fully reducible fat-containing femoral hernia. Now, this next patient, was a 43-year-old male at the time. This patient was a sonographer, and actually that patient is me. That is my hernia that I had a few years ago. These images were taken by a sonographer, Jenny Parks, who I'm sure you're all aware of. And we were taking these images for my talk, and we had taken a whole lot of city clips of the hernia reducing. It was all very well, and we got off the table and we were having a bit of a chat about things, and I started to feel really quite ill. I got this quite a bad pain in my groin, and I started to feel nauseous and I got all sweaty, and I felt down, and in my inguinal region there was a lump the size of a lemon, and it was very sore and very painful. So, of course, immediately turned the machine back up on the table, had a look with the ultrasound, and it went from being a nice, simple, reducible hernia to something that looked like that in about 10, 15 minutes. You can see there that is a strangulated, incarcerated hernia. There's fluid in the bowel. There's fluid around the bowel. Trying to push it back. It's now getting quite painful at this stage. I'm really not enjoying the ultrasound. So I'm going to draw my knees up towards my chest and continue saying, no, put your legs down. We need to do more pictures and get a better look at this. And over the next few minutes, you can see the hernia is getting worse and worse by the minute. And there it is there, looking very sore and very painful. And that is definitely an incarcerated, strangulated hernia. And by now I'm thinking, I'm going to have to go to hospital. I am in real pain. So we decided, I was going to have to push it back. But, of course, we had to get a video of it. So you can see here the next video clip, scanning over that herniated piece of the bowel, and I'm pushing, and nothing's happening, and I'm pushing, and then all of a sudden it pops back into position. And I'm not sure who yelled out loudly at the time, me or Jenny, because it scared Jenny and it hurt like you wouldn't believe as I was having it done. So you can see there that these hernias can go from being quite innocuous to quite bad very, very quickly. Okay, moving on, let's have a chat now about umbilical hernias. This is where you get herniation through or around the umbilicus, i.e. through the linea alba. Now, true umbilical hernias are much more common in children than they are in adults. If you see an adult with one, most commonly it's going to be a para-umbilical hernia. Now, these hernias are of greater risk of complication because they can strangulate, and they're often incarcerated. We have some examples of a para-umbilical hernia here. So we can see quite a large defect there in the linea alba, and we can see the abdominal fat there coming up through and forming a little hernia there. Not always that obvious. Sometimes they are quite hard to see the fat moving in and out. In this next view, we can see that this hernia is not fully reducible. They're often not fully reducible. Here's an example here. See quite a large defect there, and you can see that intra-abdominal fat going in and out of that defect with the umbilicus a fair way away on the right-hand side. There's a little tip there. It's almost through. So, as I say, these often strangulate. So these will be repaired because these can become quite painful if they do strangulate. You can get these hernias up high in the epigastric region. This is a pediatric patient we had not that long ago, and these ones often are not reducible. And you can see there's very, very little movement going through that defect in the fascia. You just get the hint of some fat moving in and out. So often with these ones, they're very tight, they're very firm. You don't get much of a movement through the defect in that linea alba, and they are often incarcerated. They can't be pushed back. Now, this next example is actually an umbilical hernia in an adult. This is quite a large patient. You can see the amount of percutaneous fat there. So you can see the hernia, the fat coming up through the umbilicus and going along the umbilical stalk. Now, in this patient, the umbilical stalk is about a 45-degree angle, so the umbilicus, the skin is right to the right of the image there. So we can see that abdominal contents coming up through the umbilicus, going along the umbilical stalk, right up towards the umbilicus at about a 45-degree angle. So that's one of the umbilical hernias you get in the adult. And this one was fully reducible. Often they're not, and they can strangulate, and you can get some complications. There we are, a little warning there. I know it's approaching dinner time for a few people, so if you're having dinner and you've got a bit of a queasy stomach, perhaps now is the time to look away. So this is a bit of a complication of an umbilical hernia. There it is there. This is a 28-year-old woman. I think they were somewhere in Africa, Angola, somewhere. She had a spontaneous rupture of an umbilical hernia in the 7 months of her unsupervised pregnancy. She had 4 previous pregnancies in the past, and she had this umbilical hernia since childhood. It was never treated, and with each pregnancy, the hernia had got worse. And now she has, in this pregnancy, perforated, or she ruptured her umbilicus. That's bowel coming through there. So she's walked into the clinic looking like this, and of course the first thing they did was take a photograph of it even before they laid the patient down, which I think is, they're breathing pretty tough over there, I think. Now, this patient did have surgery. They took out that bowel that had ruptured. The uterus and the fetus was actually in the umbilical hernia sac. So they repaired it all, put it all back, and her pregnancy went through term, and it was uncomplicated. She had a normal birth after all that, so they survived. The fetus survived, which was good. So moving on, that's enough of that at dinner time, I think. So I'll have a talk about Spigelian hernias now. These are actually quite rare. They only account for about 1% of all umbilical hernias. And with the Spigelian hernia, you get a herniation through the transverse aponeurosis and the internal oblique aponeurosis, and you'll get the hernia sac spreading out underneath the external oblique. Now, surgery is often advised in these patients because there's a greater risk of strangulation, and you can see there that hernia sac going through the transverse and the internal oblique aponeurosis and layering out underneath that external oblique. Now, often these hernias are difficult to diagnose clinically. They're more commonly seen on the right-hand side, and the reason they're hard to diagnose clinically is because commonly there's no lump felt. Because that hernia sac is actually underneath that external oblique muscle, there's no lump. And often the only presentation is pain. So if you're doing a scan for, right legs, lots of pain, obviously we're going to be thinking about gynecological issues. You're going to be thinking about an appendix. It's always worth having in your back of the mind that it could be a Spigelian hernia, and it only takes a minute to have an assessment of that area, a little Valsalva. And it may well give the diagnosis if there is a pain, if there is a hernia found. But they are quite rare. As I said, they occur more commonly on the right-hand side, and there's an area called the Spigelian belt where you get most of the hernias occur, and that's the area about 6 centimetres above the interspinous plane, which is a line joining the ASIS. So more commonly you're going to see these hernias on the right-hand side, in between basically the umbilicus and the ASIS. That's the most common area you're going to see them. Here's some still examples. On the left-hand side is the non-stressed version, and on the right-hand side you can see some abdominal fat pushing up in between the erectus and the oblique muscles on the left-hand side. This one isn't layering out underneath that external oblique, so this is an early Spigelian hernia, but a Spigelian hernia nonetheless. On this next little clip here, we can see the hernia coming up next to the rectus, layering out underneath that external oblique, in between the external oblique and the internal oblique there. So that's a true Spigelian hernia. As I said, surgery is often advised in most of these patients because there is a greater risk of strangulation. And you can commonly get what's known as a Richter type hernia, where you get herniation of only one wall of an intestine, and that obviously can lead to ischemia of that intestinal wall, which is obviously now a bit more of a serious medical issue. Okay, we can also get incisional hernias, where you get a hernia at the site of previous surgery. Most common after bowel or gynecological surgery. Pardon me, they make up up to about 30% of major abdominal surgeries may result in a hernia. You can often get them at laparoscopic port sites. They're more common in obese patients, and multiple surgeries increase the risk of hernias. They may take many years to develop, but most likely that they occur to 3 to 6 months after surgery. We can see an example of an incisional hernia here. This is a 42-year-old male that had a previous appendectomy, complicated by a number of incidences of peritonitis. He has a large scar there in his right lower quadrant, a bit of a bulging there of the tissues and that swelling. And this had developed over a number of years. When we did the ultrasound straight over the top of the scar, we can see some bowel there coming right up into the scar there, right up near the skin surface. We did a little bit of a panoramic shot here. We can see on the right-hand side of the rectus muscles there, the left-hand side of the abdominal obliques, and there's quite a large gap there between the obliques and the rectus muscle, and we're scanning right over the scar. So this is in fact an incisional hernia with the bowel bulging up there through the incision. As I said, we can also get incisional hernias through a laparoscopic port side. This is, you can see here, quite an obese patient with bowel coming up through an old laparoscopic port site there. This patient went on to have a CT scan, and we can see a CT scan here of the same patient. We can see the bowel coming up towards the skin, and that's a little incisional hernia through a port site. And you can see, if you have a look on the right-hand side or the left-hand side of the patient, you can see those abdominal musculature is very, very thin there on these obese patients. So once you puncture that abdominal wall, you can easily imagine how you can get a hernia through that area, through that laparoscopic port site. Moving on now to, as I said, the varication of the abdominal rectus. This is where you get a separation of the left and right rectus muscles. The linea alba, which is that fusion of the aponeurosis that is between the rectus muscles, that's still intact. There's no tear in that linea alba. It's just widened and stretched. Now, if your rectus muscles are separated by anything greater than about 2 centimetres, that's usually considered positive for divarication. And I'm sure you've all seen that visible midline bulge, an abdominal tension when a patient gets off the table. Well, that's divarication of the abdominal rectus. As I say, technically not a true hernia because the vertebral cavity is still intact. You just get that bulging because there's no muscle overlying the abdominal contents, and you get the bulging, which we can see there on the right-hand side is non-stressed and the left-hand side is stressed. And you get that bulging of the abdominal contents in between the two recti muscles there. We have there on the left-hand side the rectus muscles there in close-up position there, and on the right-hand side when the patient stresses, you can see the abdominal contents bulging through in between the two recti muscle, and that's a divarication of the abdominal rectus there. All right, so some take-home points when we're doing hernia ultrasounds. A properly performed Valsalva is really critical and vital to the hernia, and it is well worth a little extra time to get this done correctly. If you don't see a hernia, it's always worth doing the patient standing up, because often you'll see a hernia that you wouldn't have seen if they were lying down. It really is quite important to identify the contents of the hernia sac, and that really is the main reason why we're doing these hernias. And you need to know if there's any bowel in the hernia sac, and if there is bowel, are there any signs of strangulation? So you've got to learn those signs of strangulation that we went through earlier. And if you see bowel there, you see strangulation, you really need to bring that to a doctor's attention, because they're going to need some urgent medical attention on that. Now, it's always a good idea, if you can, to determine if it's a direct or indirect hernia. It's always good to give the surgeons as much information as possible, but you don't need to get too concerned if you're unable to decide. It's not that vitally important. What is much more important is that you decide, is there any bowel in that hernia sac, and are there any signs of strangulation? That's what we're really doing these hernias for. Okay, so we've had a few questions come through here. Let's have a look. It says, do we have a question here from Cheng Yo from MIA? And the question here, is it important to measure the hernia defect? Yes, it is, because that can help the surgeon know whether surgery needs to be planned immediately or later. And if you see a defect in the hernia sac, it's always good to give the referring doctors and surgeons as much information as possible, and it can alter their management if they know about the size of that hernia. So, question here, how do you differentiate between an umbilical hernia and a para-umbilical hernia, which is very close to the umbilicus? It can be very hard. That was a question from Sarah Doyle from MIA. It can be actually very, very hard. But normally, if you scan over the umbilicus, you should be able to see the umbilical stalk coming from the skin surface, going down into the peritoneal cavity through that linear elbow. And if you can follow that umbilical stalk down and see it entering the linear elbow, that's where the umbilicus is. And if it's not coming up through that stalk, that's going to be a para-umbilical hernia. If it's coming up through the umbilical stalk, which goes all the way to the umbilicus, that's more likely to be a para-umbilical hernia. Now, we've got a question here from Benita Fu. If you see fluid only, does it always mean bowel is involved? No, you can get fluid in the hernia sac without there being bowel involved. You can get just fluid and fat. So you really do need to see if there is any bowel involved. Now, sometimes it can be a bit hard to distinguish between edematous bowel and fat, but more often than not, you can distinguish between fat and bowel, and it is possible to have a hernia that is strangulated. So you're going to have fluid in the hernia sac, but you're not necessarily going to get bowel involved. It's going through some more. We've got a question here from Belinda Target. Can you have both an indirect and a direct inguinal hernia at the same time? Very good question. Yes, you can. When I went through our packs the other day, I couldn't find any, but that's actually known as a pantaloon hernia, because the hernia looks like an old Spanish pair of pantaloon pants. So you get bulging in two different legs. So absolutely, you can get a hernia going through the deep inguinal ring, so it's an indirect hernia, and at the same time you can have a hernia coming up through that posterior wall as a direct inguinal hernia. So absolutely, you can have. We have a question there from Maria Gonzalez probably. What are the chances of getting bilateral hernias? I'm not quite sure what the chances are, but they often happen. It doesn't hurt to always have a look on the other side. If you're seeing a hernia on one side, it doesn't hurt to have a look on the other side as well. Make sure there's not a hernia on the other side. It really does depend on your department protocol whether you do that or not. Some departments I've worked in, and some radiologists I've worked with, always insist that we have a look on the other side as well if they've seen a hernia on one side. Often if the patient is going to go in for surgery on one side, they will do the other side at the same time. It saves an extra anaesthetic and all the extra risks that are involved with normal surgery. So once again, it's all about us as sonographers giving the referring doctors and the treating physicians as much information as possible. And if it is going to affect their management, if it is going to mean they'll have to have both sides repaired, then it's always good to it's always good to give them as much information as possible. Okay, a question here from Jennifer Gardner. Fat in the inguinal canal of movement moves through the superficial ring. Would you call this a hernia? It depends where the fat has come from in the first place. If you have fat that is in the inguinal canal and it just moves along the canal and it may move down through the superficial ring, that's not necessarily a hernia. You can get lipomas within the inguinal canal. That's not uncommon. That isn't a hernia because that lipoma hasn't come, or that fat hasn't come from the abdominal cavity going into the inguinal canal. So that isn't a hernia. But that can be a lipoma just moving along the canal, and it can easily slide through the superficial ring. So I think that's probably about all the time we have with questions now. So I'm just going to hand over to Rhonda from Phillips. And once again, I'd like to thank everybody for tuning in this evening. And thank you very much. And thank you, Rhonda.
Hi. I'd like to thank Andrew very much for the fantastic talk on the hernia. I hope everyone got as much as I got out of this hernia talk, and it was absolutely fantastic. Thank you all for joining us, and please tune in to our next webinar, which is at the same time on Wednesday, the 9th of November. Ling Lee will be presenting on first trimester maternal uterine artery Doppler. Don't forget the CPD point certificate. Press the button at the bottom also. So you can get the CPD point certificate. We also will be sending out the registration details shortly. So please register when it comes out. Okay, thank you guys for attending, and good night.